Hi and welcome. I'm Dr. Anthony Levinson, a psychiatrist at McMaster University, and my colleague, Dr. Richard Sztramko, geriatrician extraordinaire, and we're happy to bring you iGeriCare's 16th live event, coming to you from McMaster University on February 5th, 2020. Thanks very much for joining us live or watching the recorded archive if you're joining us later on this week. For our 16th live event, we thought we would tackle some of the most common myths, debunking the dementia myths, and there are many. I was saying earlier, this is kind of our opportunity and your opportunity to send in questions on any topics related to dementia caregiving. It's our potpourri category where we're going to cover a lot of different topics. So today we'll try to address some of these common points of misinformation and separate fact from fiction when it comes to dementia. So welcome, Richard. And why don't we dive right in there with a few of the most common myths. And we're also grateful for folks who have sent in questions in advance. You can also use the chat bot or chat pod on our igericare.ca/events page, or if you're watching us through the Facebook live stream, you can use the commenting box. So, myth number one, there's nothing you can do for your brain if you've already been diagnosed with dementia.
Yeah, so there are definitely things that you can do to help your brain function better if you have been diagnosed with dementia. So some of the easier fixes are around medications, and if you're on some bad medications and you have cognitive impairment, certainly modifying some of those medications, whether they're pain medications or sleep medications, can improve your cognitive function. Or let's say you're not sleeping well and you have bad or poor habits around sleep, then certainly that will help as well. We always talk about the lifestyle changes that people can make, and it's not clear that they have the largest impact, right? So exercise certainly does boost cognitive performance in people that have dementia. It's not like it's altering the underlying disease process necessarily, like getting rid of toxic proteins, or it's not reversing vascular or blood vessel damage in the brain, but certainly can help boost how people perform. Diet as well is one of those things. In particular, the Mediterranean diet has been shown in people that have cognitive impairment to actually improve some of their testing scores somewhat as well.
I think one of the things that we've often tried to clarify is there are many different types of dementia, and so it's an umbrella term or a general term for a number of different disorders. And so in terms of things that you can do for your brain, some of that differs a little bit by the disorder. So if you've got the type of dementia called vascular dementia and you've had strokes, then improving your management of your blood vessel health or your blood vessel health, vascular health through managing your blood pressure or reducing your cholesterol, that's a particularly useful thing to do in that particular subtype of dementia.
I think that's a really important distinction too, because there's managing your blood pressure generally or managing your cholesterol in general, or trying to keep better control of your diabetes in general and reducing your overall risk. And the evidence is a little bit less clear in those situations. Some trials have shown that, yes, it may decrease your risk somewhat, and some have shown that no, it doesn't. But certainly if you've had a stroke or multiple strokes, the secondary prevention medications for that and controlling your blood pressure, taking an aspirin, things of that nature are very effective at preventing your risk of further stroke and subsequent cognitive decline. So I think we've busted that myth.
Okay.
Yeah, there are things definitely you could do. We always, just to mention the staying socially active. Again, not as much evidence around that, but definitely something we encourage people to do, and staying cognitively active with some brain training activities. Yeah, so a very degree of quality of evidence on what works, but definitely things you can do.
I guess we could say there's plenty of things you could do to make it worse too.
That's a great point.
The opposite of some of those lifestyle things, and being on too many medicines and continuing to smoke heavily. There there's a likelihood that you might be able to make things worse through
decreasing alcohol intake versus continuing on moderate alcohol or heavy alcohol intake. So,
all right.
Definitely.
Myth number 2. Because someone in my family has dementia, I'm going to get it.
Yeah. So for most people, the large majority of people, that's not true. There are certain genetic mutations that if you carry it in your family, it will mean that you will get it. So we've mentioned them before, I think, amyloid precursor protein, presenilin 1 and 2, and Down syndrome to a certain degree. That's less guaranteed, but they really increase your risk. But that's a very small percent of people that actually have dementia overall.
So most people may not have a family history, and even if you have a family history, your risk of developing it's not like 100%.
It's definitely not 100%. You know, it may increase it 2 to 8 times, but when there's a family history and there's 28 different genes that might all interact in a complex way, there's no way to tease it out, and so...
And sometimes sometimes different types of dementia.
100%.
So it's not even necessarily the case that the people in the family with a dementia have the same type. Those kinds that we've talked about with strong genetic components are often younger onset, or just very, very loaded family histories where many people in the family develop the dementia. So myth number 3, dementia only affects older people.
And this kind of dovetails nicely from the last question, that people that have the genetic related or inherited forms of Alzheimer's disease will definitely have onset earlier on in life. So perhaps in the 40s and 50s, whereas most people that have an age-related dementia will have onset after the age of 65. So it's definitely not true, and that only older people are affected by dementia.
Age is one of the most important risk factors for the most common types of dementia. So I think that's where that myth arises, is that most of the people with a dementia are older adults. Alzheimer's disease tends to affect older adults, but there are absolutely some of these younger onset dementias. Very few in the Alzheimer younger onset, but some of the other dementias do have the younger onset.
It's true, and I should say, not all people that develop Alzheimer's early in life do have a genetic component. I should make that distinction as well.
That's kind of a statistical thing, isn't
right,
it? The sort of the normal distribution.
Yeah.
Alzheimer's is the most common cause of dementia, so you will invariably get some people who get it at a younger age and others who may get it at an older age.
And we don't know exactly why that takes place. And you'll see, to your point on aging, seeing the increasing prevalence across the population. So around 8% of people above the age of 65 will have dementia, around 15% around over the age of 75. And as you're getting above the ages of 80 and 85, you can approach 25% in the general population, and much higher numbers in places like long-term care.
And I think that's as the population in Canada and around the world continues to age with an older demographic. I think that's why we are most likely seeing many more cases of dementia in terms of the prevalence.
Absolutely.
All right. Myth: memory loss equals dementia.
So again, let's bust this myth. I feel like we should, have our show on different avenues or networks now that we've turned it into a Mythbusters episode. So there's lots of reason for memory loss. We've talked about them at length before, but depression can cause memory loss. People can forget things just out of the blue. It happens to me, it happens to you, and it's not problematic. There are also people that will have subjective cognitive impairment, where they're worried about what's happening to their memory, and they'll be concerned about having just normal memory loss that happens intermittently, and they don't actually have anything
We've talked about
wrong with them.
Medication side effects being another one. Depression, occasionally anxiety. It's not so much memory loss, it's more poor attention. so that the memory doesn't kind of connect because somebody's distracted or
Thought blocked.
Yeah. So I think it's not to dismiss the fact that memory is, like poor memory is an important symptom of dementia, but there are a lot of other causes of poor memory. And to your point, it's usually more than one type of cognitive domain. So it's not just memory that would be affected in a dementia, it's language, memory, what we call executive function, where somebody is doing planning or abstraction, visual spatial awareness, where somebody's body is in space and things like that. All of those things contributing or coming together with or without problems with memory and interfering with the person's function. So an isolated memory problem could be lots of things and not necessarily dementia. All right, here's a good one to talk a little bit more about. Dementia is preventable.
So your brain health encompasses a lot of different things, and there's a lot of aspects of your life and your health that feed into your overall brain health, and many of which we've mentioned. And if we framed it as, if you exercise, you will prevent yourself from getting dementia, or if you stop smoking, you will prevent yourself from getting dementia, or if you eat the right foods, you'll prevent yourself from getting dementia in absolute terms. We're only ever talking about shifting risk levels. So if you had a lot of risk factors and you altered some of them, then potentially you can decrease your overall risk. For instance, people that are in midlife, that are in the top 10% of people that are exercising in terms of how active you are, have much lower risks of getting dementia later on in life. But exercise is also associated with a lot of different things. The people that are exercising that much are probably sleeping better and they're eating better. So it's difficult to tease some of those issues apart, but definitely there are associations with overall healthy living and eating right and exercising and not smoking and not having excessive alcohol intake that can be associated with a lower likelihood of getting dementia.
I feel like this particular myth's status it's complicated because it's really important to think about what we call primary prevention, secondary prevention. Can you prevent the onset? Maybe not, but can you maybe delay the onset? Can you improve your cognition or modify as many of the risk factors that you can? And should you do that to promote your brain health? That's a good idea, but you're probably not going to necessarily prevent, but you might delay onset, or you might improve your function, or the disease may not have the same symptoms or things like that.
Or rate of progression.
Yeah.
Yeah.
So I'm gonna cut because we're getting lots of really good live questions coming in. So I'm gonna we'll come back to some more myths, but why don't we take a few questions? So here's one that came in earlier this week. Does coconut oil help stop dementia?
There's no evidence that coconut oil helps stop dementia, either a treatment or from a prevention point of view. There was some thought around using different fuel sources for the brain instead of using glucose as you normally do, using ketones and other things, but there's been no evidence to suggest that that's actually helpful.
I think there was some research that was done in the lab a few years ago where they looked at the effect of coconut oil. I can't remember if it was either an animal model or whatever that showed some relationship to some of the chemicals that seem to be involved in nerve transmission in Alzheimer's. So people got quite excited about it. And the bottom line is there's really no compelling evidence that suggests that it can prevent or improve dementia at this time.
I think that's the challenge too with a lot of the dementia-related research is we'll find something that will be very encouraging in a mouse model of Alzheimer's disease, but when you take it out of animal models and put it into the real world, it doesn't work. And the same thing for observational trials, right? So like if people that take more vitamin D are less likely to get dementia or things of that nature. But when you actually put people in randomized control trials where you're isolating and giving vitamin D or not giving vitamin D, it doesn't help. And That's the same thing for a lot of the different alternative therapies that get grouped in together. So like ginseng or ginkgo, or the vitamins, like using vitamin B12 as a treatment or trying to prevent it. None of those things have been shown to actually work and halt progression of the dementia.
I think we might be coming back to this as a general theme where the quality of the research behind saying something's a risk factor or a treatment, the quality of the research may be lacking. So, which isn't to say that new findings might not come down the road, but it does mean, right now there's not enough research to say you should take coconut oil.
Definitely.
What is the lifetime expected for someone with this issue? So I'm not sure I fully understand, but I think maybe it's a question about how long would somebody live with dementia? Life expectancy?
Yeah, I find this challenging. You can see different numbers published in the scientific literature from 5 years to 15 years, but we do know that some people progress very rapidly. And you keep bringing it back to the point of dementia being the umbrella term, and so it depends. Like, do you have Alzheimer's disease? Do you have frontotemporal dementia? Do you have a Parkinson's-related dementia? Do you have dementia with Lewy bodies? All of those different diseases shift things.
The somebody with vascular disease is they may have had vascular dementia with multiple strokes. They probably also have cardiovascular disease and may be more likely to die, or that's another risk factor for death from a heart attack and not just another stroke or things like that. So.
And there's people that we'll see that will progress for periods of time and stabilize for long periods of time and then progress quite rapidly, and mixing each one of those things in, you don't know what's going to happen. I'll often tell people the rate of progression that you're seeing now, you can expect to continue to see. And as a general rule, that's accurate in my clinical practice. That's about as good as you can get for people. A lot of times people want hard and fast numbers, and certainly if you're at the end stages, it's a little bit easier to predict.
Yes, I think if somebody has more advanced disease and they've stopped eating and drinking regularly, or they're no longer able to leave the bed or walk, then I think it's easier to guesstimate life expectancy.
And it also depends then on the stage that you're diagnosed. Yeah. So if you're diagnosed at an early stage, you'd expect somebody to live for a much longer time.
Yeah. Do mercury dental fillings play a role in brain health developing dementia? I've read that mercury from dental fillings may be linked to high blood pressure, infertility, fatigue, MS, and Alzheimer's disease.
Yeah, there's no link that I'm aware of. I think people have looked into this quite extensively, and there's nothing to suggest that mercury increases your risk.
Yeah.
On the dental health, there's very, again, preliminary scientific evidence that some of the bacteria that live in and around your gums can actually drive cognitive impairment or some dementias, but it's very early days looking into that side of things. So maybe floss your teeth and keep your good dental hygiene, but again, it's not a high quality recommendation on that side of things.
Yeah, it's interesting too. I think this myth goes back over a decade ago, and I think I noticed that there's a lot of different groups who have published sort of positions on this, from the American Dental Association to the Mayo Clinic to the Alzheimer's associations, and there's still actually some research being done on this. And again, going back to, this is kind of a challenging thing to study. There aren't a lot of prospective trials saying, well, we're going to randomize you to dental fillings with or without high levels of mercury. We know that mercury in high levels is a neurotoxin, but what seems to be the consistent message is there really is no evidence of an association. I can't speak to all of those other things, but I believe the same findings are with those other conditions as well. There is still some active epidemiologic research being done in this area, but at this point, almost everybody has published sort of a same thing. There's really no evidence, and you don't have to go and get your fillings taken out and replaced at this time. And actually, that the amalgam fillings have a lot of other health advantages. I think that's the feeling, is they're actually a pretty good material for dental fillings. Can aluminum-containing antacids, for example, aluminum magnesium hydroxide, increase the risk of dementia?
Again, I think it's a similar response to the last question. There's no evidence suggesting that there's any association between those two things. I mean, there are other things, usually calcium, in those medications, and so there are some people that will actually have excessively high levels of calcium just from consuming antacids. So certainly if that happens, high levels of calcium can cause some cognitive impairment, but you stop taking the medication and the calcium levels go back to normal and your cognitive capacity should go back to normal.
Back to your point earlier too about the quality of the studies around this. When people look at these types of studies, they often may find an association between, say, dementia and those that take antacids, but that doesn't necessarily mean it's a cause. And we've talked before about there are certain things like vitamin B12 deficiency that can lead to cognitive problems. People who take a lot of antacids may affect the absorption of other nutrients or vitamins, which might in turn cause other symptoms. So there may be some association. I think there have been a few studies that may have seen some kind of association, but they're not necessarily strong evidence. So.
And I mean, things that increase acid secretion that you might want to take them for, heavy alcohol consumption or other fatty foods, or the associations you're talking about.
Here's a question from Toronto today. Is it possible for people with dementia to learn new skills? A definite yes to that, but again, the question, what is the stage of the person with dementia? What is the type of dementia? Because there's actually differences between the types of dementia and skill acquisition. But I don't know if you want to say a little bit more about that.
Well, I think that makes sense. I think learning a new skill could be a procedural skill too. So, it's whether it's solving a certain type of puzzle, or using an instrument, or doing arts, or doing crafts, or doing things around different things around the house. Obviously, if you're having really challenging short-term memory problems that are severe, you can't remember the information and kind of take that in, so it makes it much more challenging. Or if you're, let's say you had dementia with Lewy bodies, or an Alzheimer's patient that had really significant visuospatial awareness problems, then trying to learn a skill like painting or something else would be very challenging for them. So I would just echo your comments. It's very individualized, and I think that's how we'll present learning skills or taking on activities to people and try to figure out what are the cognitive impairments that they struggle with, how severe are those cognitive impairments, and then tailoring the activities that they're getting up to their strengths and things that they're still able to do. So it needs to be very individualized.
And I think probably one of the single most important things that we've just talked about is not like a one-size-fits-all. There's individual people and their preferences and motivations and what they might be interested in learning. There's the stage of dementia, and people in mild to moderate stages will be more capable of learning new things based on their memory impairments and use of language and motivation, whereas those with more advanced dementia may be more challenged to learn new skills.
Yeah, and they might not be interested in the skills, but more a stimulating environment, or an environment that's more pleasing to them.
Do people need to give up their license immediately after they're diagnosed, early stages?
So there are different guidelines on this, and the challenge again is that there's no one test that we can do for people that will provide a cutoff of yes, you can drive or not. So the Canadian Medical Association says that you don't have to stop driving if you have mild dementia, but if you're starting to show signs and have impairment in 2 instrumental activities of daily living, then that's a pretty reasonable cutoff. But again, you could have mild dementia and have very challenging visuospatial awareness, and so you can't judge distances appropriately, and you can't navigate through familiar environments very well. Those are really necessary functions for driving. So it's not just that you have a diagnosis, it's what's coming along with that on your individual level. And then talking a lot to families, I think, is more important. Do they feel safe with that person in the car? Have they gotten in previous accidents, or do they have bumps and scrapes on the car? Are they having emotional outbursts or doing things in an impulsive fashion while they're in the car? Are they having challenges with executive function? Because if you think about driving, you're looking around and taking in the environment and planning and ordering a sequence of actions to do things. We take it for granted as second nature, but it's a really complex process. So.
And there may be other medical issues or medications that might in and of themselves not necessarily be a problem in terms of medical fitness to drive, but it's possible that if somebody has a mild dementia and has some kind of mobility problem that makes it challenging for them to turn their head or use their mirrors or something, or they're on a medication that causes a bit of sedation, those things taken together may make somebody medically unfit to drive. Another question. Environments like dementia villages are better for people with dementia than traditional institutional settings, retirement homes, assisted living, long-term care homes. This seems to be a statement rather than a question. So, I guess what is your opinion on environments like dementia villages are better for people with dementia than traditional institutional settings?
I think this is an area of active research, and the preliminary information coming out seems to suggest that people will be happier from a face validity point of view. It makes a lot more sense to me that if you have freedom to wander around someplace and everything's very easily visible in terms of directions to where you're going, or it's a more stimulating environment. But maintaining autonomy and being centered around that person's life, it makes sense that people would be happier there and be more engaged in their environment and have an improved quality of life. I think they're starting to spread all over the world now. We have our first one out in British Columbia right now. I think they started in the Netherlands or in Scandinavia, but I think we will see a lot of information come out about how this impacts people's lives, and you'll probably see more and more long-term settings go in this direction. I think the challenge is that it takes a lot of resources to get this going, so it's not like you're going to transition all of the government-run long-term care facilities to a dementia model, and they're charging premium prices for them right now. So
I think the cultures, not all traditional institutional settings, which was the term used, are created equal. I think you probably have quite a bit of variability in the cultures within an individual setting. Retirement homes are certainly quite different from long-term care in terms of the needs of folks. So anyway, I guess the jury's out, but preliminary.
Moving in the right direction.
Yeah. Does eating certain foods slow the progression of dementia?
It seems like slow progression is one of the challenging features, because most of the dementias we talk about are talking about the accumulation of these toxic proteins, whether beta amyloid or tau and Alzheimer's disease as an example. So there's nothing to suggest that eating the right foods, we mentioned the Mediterranean diet, slows the progression or what's happening on the cellular level, but we might be able to mask or improve the brain function that's happening around it, or potentially help improve the connections in the healthy part of the brain to kind of diminish the way you experience the disease in the brain.
And maybe what we were talking about, that certain types of diets might be better for your overall vascular health, so they may be beneficial from that standpoint. I always worry a little bit, and it's hard to know with the question, but I think, again, back to one of the myths around, this vitamin, this supplement, this mineral, is the key. I think there's often a lot of hype around, well, this is like a superfood, so eat this food and, you'll be cured. So I always worry a little bit about hyperbole, and again, especially if somebody's selling that particular superfood or drink or supplement, there's always a risk that there's really not great science to support that specific food, or and somebody's just trying to sell you some snake oil. So.
I think that's fair, and it's not like people are wrong. It often leads to people come up with a hypothesis that something works, and then it leads to like a 10-year period where people play it out in the scientific literature and actually need to study it. I mean, like probiotics, for instance, right? Like that used to be a little bit more on the alternative, hippy-dippy side of things, and now all of a sudden people are coming out with designer probiotics and studying your fecal microbiome and trying to cater very specific probiotics to what's happening at baseline. And so, you might see some evolution, but I agree, it's not like you eat this diet and it's going to solve all of your problems, or you eat this diet and it's going to, stop the dementia in its tracks.
Hard to do the research, and I think just like people lump together the dementias sometimes, hard to do the research when we may be looking at people with multiple different types of dementia. So maybe certain foods or a certain diet might help with a particular subtype of dementia, but dementia research has not been well funded, and that's one of the things that the National Dementia Strategy is hoping to help with. So. We have, do all individuals diagnosed with early onset dementia experience a rapid progression of their symptoms?
No. There are people that will progress at a slow and steady rate.
So it starts early but doesn't necessarily progress more rapidly.
Slowly. And, it also depends on the case series that you'll read, where it's like they'll take a bunch of people and study people with just Alzheimer's disease. Alzheimer's disease is thought as a slowly progressing illness over time, and the majority of people do. But depending on the series you read, 10 to 20% of people, which is not an insignificant amount, can progress quite rapidly. So rapid progression happens in older individuals. It also happens in younger individuals. And slow progression happens in older individuals and younger individuals. So.
Good. We have a question from Edmonton. What is the likelihood that dementia is genetic?
It depends on that person's genetic profile, I would guess. So what's the likelihood in an individual that the dementia is associated with their genetics is going to be completely dependent on what that person's family history is.
Yeah, it's a really tough one. One, I'm going to say we don't really fully understand all of the different causes, or some of these more complex genetic disorders. So I think back when Huntington's disease and the gene for Huntington's was described, there was optimism that there'll be more and more of these type of like one gene equals this disease. And with many medical conditions, it's a lot more complicated in terms of, there may be certain genetics, but coupled with an environment, or multiple genes might be affected, and that might increase one's risk, but not necessarily be a causal thing. So hard question to answer, because it also depends. Again, there are some families where there is a more clear, genetic influence over the development of dementia. I don't know if there's been, again, I don't know if one can say in a general way, what percentage of somebody's dementia is related to genetics versus other factors.
It's hard to do in the real world setting too, because we don't sequence everybody's entire genome, and so as time goes on, more and more alleles or spaces on chromosomes have been identified. So let's say there are 28 of all these different things, and they're just an association, and it's hard to say whether, well, if you have 24 out of 28 of those gene issues, you're going to have this amount of risk, or 2 out of 24 and it's going to be lower. Like, it's very hard to make those calculations, and I'm not, like, that really would take a geneticist and a population level researcher, I think, to answer that question appropriately.
It's probably not out of the question in the next decade that those companies like 23andMe or other companies that scan the genome, you know, as more of that association data comes out, there might be some more predictive value. And then the question comes, does that enhance or not your quality of life to think in advance that you may have a slightly increased risk of developing something?
I think too, just mentioning the ApoE4 gene alleles, and if you have 2 of those, then it does significantly increase your risk. So, you know, if you have both of them, almost 100% chance that you'll get dementia by age 80. But again, it's, you know, what do you do with the information in advance, and you know, how would it change your management, and how does it change your life? So I think when you get into the genetic side of things, and there's a strong family history, or potentially early onset, and people really want to narrow in on what their likelihood of progression is, then helping with a genetic counselor. Like, this is sometimes somebody's full-time occupation, to understand all of the genes and the risks and benefits of, you know, testing for various genes.
Our lesson on how to promote brain health within iGeriCare, if you have those 2 ApoE4 genes, it's worthwhile to do it, because you can help to promote your brain health. And if you don't, you should do it too, because these are all things that you should do to promote your brain health, irrespective of your genetic risk.
And your general health too, right? It's like, if you're, most of the things we're talking about help your brain, and they help your heart, and they help your blood vessels all over the rest of your body.
Can you speak a little bit to what you know about emerging best practices for dementia care in long-term care settings? For example, the dementia village model, where residents can live in a community-style setting rather than in a facility. So I guess, are there any emerging best practices? I mean, I think there are certain things about not just dementia villages, but if you look at person-centered care being one of the buzzwords, person-centered language, ways of respecting human rights and individuals. Like, I don't know if there's any other specific best practices where there's like strong evidence around this.
Yeah, and I mean, I think things like the Health Quality Ontario standards, it's not specific for long-term care, but they are a checklist of, and a roadmap that everybody who has a diagnosis of dementia should follow, in terms of, you know, having a point person that directs your care, and having access to multidisciplinary care, and understanding what the plan is, and understanding what to do when you fall off that plan. So there's kind of guidelines that are coming out where people can follow a checklist along to make sure they're getting the most out of their care. Or there are things like the Gentle Persuasive Approach program, in terms of educating people in long-term care about responsive behaviors, whereas before a ton of people were just getting antipsychotic medications, which have a lot of risks and side effects associated with them. And now there are education models that are being distributed, and certainly, I mean, iGeriCare isn't a best practice per se, but it is a structured information system that allows people to get the most information possible in a condensed and easy to digest
and as you
format.
say, like a lot of the best practices out there are about, you know, providing resources to people living with dementia and their caregivers. I have an interesting comment that was just sent in related to discussing kind of dementia villages. So it's not a question, I'll just share that, this comment, because it sort of relates to this topic. My opinion about your statement about dementia villages versus assisted living nursing homes is that it doesn't matter where they are if there's no one to communicate with. My mother's in an assisted living nursing home. I believe her decline has escalated with none of the other residents able to carry on a conversation. She's so excited when I show up to take her off the secure unit and walk and talk with her. Now, after 7 years, she does not know who I am, but still shows excitement that I'm someone familiar. Yeah, I think that's a really really well stated point about social isolation, loneliness, the isolation that can occur even when you're amongst many others, because there could be a lack of communication and social interaction, even if you're still amongst other people living in that setting. So,
I mean, we could tie this to one of the myths. The myth is that people with dementia cannot understand what's going on around them. And, you know, it's one of my favorite patients has very advanced. I love all of my patients, but one of them.
But you're playing favorites, and now you're admitting it
just for the story,
on live web stream.
That's right. You know, he tells the best jokes. He may repeat the jokes, but he's got 6 or 7 jokes that he just tells all of the time, and you can see he lights up when he's around his wife and his kids. They're aware, and there's lots of emotional reciprocity going on, right? There's an exchange, and they're aware of love, and they're aware of kindness and all of these things. So it's like, yeah, people 100% can understand what's going on around them and have meaningful relationships with the people that surround them, irrespective of the cognitive impairment that they have. Yeah. And doesn't mean you can't feel and you're not a human anymore.
I think this person's comment too is right on, that even if the ability to communicate verbally is diminished now with her mother, or even if she doesn't always recognize her, there's some familiarity, there's some recognition at an emotional level that seems to be happening as well.
We talked a lot about verbal communication and nonverbal communication a little bit before we came on air, but that so much of communication as well is nonverbal. Yeah. You know, whether it's a touch or just being there with somebody, and your facial expression and how you are interacting with people through those means. It doesn't all have to be complex, you know, words or discussions. It can be very simple.
My experience, you know, I guess on both sides of the gurney, just to reiterate the concern about isolation in long-term care.
Oh, yeah.
I think many of the long-term care settings are really, really short-staffed, and the staff may be very caring and doing their best, but they're spread incredibly thin, especially on certain shifts, and so it's often the case that they're not able to spend time with the residents other than just sort of doing the utilitarian things that need to be done. So. My husband has frontal lobe dementia, diagnosed 4 years ago. He has short-term memory loss, but can still have good conversations, still pretty normal, just says inappropriate things to people, gets him into trouble. Can anything be done? He's on memantine. I think one of the really good resources is that Dementia Advisor app.
Yeah.
It has some really, that's from our friends at Mount Sinai, has some really, really nice concrete suggestions for how to handle situations where there may be, you know, inappropriate conversations. So there's no easy, you know, approach. Trying to maintain kind of sense of humor and patience and encouraging the social interaction is important. But that Dementia Advisor has some really good tips for how to handle some of those situations.
I think depending on the comfort levels too, like this kind of gets into the stigma around a diagnosis of dementia and whether people feel comfortable sharing or not. Like if you couldn't walk because you had a broken leg, you wouldn't feel ashamed or embarrassed about explaining that to people, and just perhaps educating people that are around him. If you feel comfortable and they're close enough, letting them know that he does have this diagnosis, and the reason that he's saying these things is not voluntary. It's not he wants to say them. His brain is no longer functioning the way it was previously or normally, and now he's saying these things as a result of the illness. So, I mean, that's another strategy.
We have time for just a couple more questions. We'll try and wrap up close to time. Does the disease affect one's ability to express emotions? And, you know, again, lots of different types of dementias, individuals affected differently, but for sure it can have an effect. And you know, we've talked about the ways in which it can have an effect in both directions. So in the example that was just given of the person with frontotemporal dementia, somebody may, you know, express emotions inappropriately. They may lose their temper or have anger outbursts potentially, or be like overly emotional. And then we've also talked a lot about how one of the common symptoms of many of the dementias is apathy, where people kind of lose a lot of their interest, motivation, and they may seem more flat and not expressing emotion. So it can definitely affect the expression of emotion.
Yeah, and I mean, I like the example of the frontotemporal dementia patient, the behavioral variant patient as well, who has decreased empathy. So the kind of interpersonal warmth and connectedness, it goes away. So that's kind of expression of emotion there too. You know, you're not actually caring for the people in your environment, and if bad things happen to them, you don't have the capacity to actually care, and that's a part of the brain-related damage, or the brain damage as a result of the dementia.
So one final question. It's a very specific one. It's a question from Vancouver. Are you familiar with Naomi Feil's validation approach?
I am not.
I am not either.
I have some reading to do after this. We're going to get educated from this online environment.
I want to thank everybody for, we didn't even get through all of our myths. We had so many great questions coming in. So thanks everybody for submitting questions and comments. This was I think it's good to have these mixed potpourri sessions, even though people always feel free to send in comments. And amazingly, we didn't talk about cannabis today. Oops, I just said it. Anyway, iGeriCare was developed originally with support from the Canadian Centre for Aging and Brain Health Innovation, or CABI, powered by Baycrest. Geris Centre at Hamilton Health Sciences, McMaster University, Hamilton Health Sciences Foundation, Alzheimer's Society Foundation of Brant, Haldeman, Norfolk, Hamilton, Halton, and our Division of E-Learning Innovation. We're really fortunate to have such a great team here, and as everybody knows, because I continue to belabor it and need a new catchphrase, teamwork makes the dream work. There is the survey pinned at the top of the comment section. Please, please, please send us your hopes, dreams, wishes for the topics that you would like us to do other live events on. Our next live event is scheduled for Wednesday, March 4th, 2020 at 1 p.m. And we have a couple of really good ideas for the topic, but you, the voting public, also get to help us. So thanks everybody, and we'll see you in March.